What if I told you that the meal sitting in front of you right now could be the difference between living to see your grandchildren graduate or dying on an operating table with your chest split open? I'm not exaggerating. I'm Dr. Olivia, interventional cardiologist with 18 years of experience. I've threaded catheters through thousands of arteries. I've deployed stents into vessels so clogged that only a trickle of blood could squeeze through. I've held hearts in my hands that were starving for oxygen because the arteries feeding them had turned into calcified tubes. And I'm here to tell you something that might shock you. The meal I'm about to reveal doesn't just slow arterial disease. It doesn't just manage it, it actively reverses it. And I have the clinical evidence and the peer-reviewed research to back up every single claim. But first, I need to destroy some myths that are literally killing people. The dangerous lies you've been told. Open any health blog right now, search how to clean arteries naturally. You'll find thousands of articles promising miracle cures. Drink warm lemon water every morning to dissolve plaque. Take apple cider vinegar shots to melt away cholesterol. Eat raw garlic to flush out blockages. Cayenne pepper to burn through arterial buildup. This is dangerous nonsense. And people are dying because they believe it. Your arteries are not drain pipes. Plaque is not soap scum. You cannot dissolve atherosclerosis with acidic liquids any more than you can wish away cancer. I've had patients come to me with 80% blockages who told me they'd been drinking lemon water for years. They thought they were protected. They weren't. They were one stress response away from a massive heart attack. The reason these myths persist is because people don't understand what plaque actually is. They picture cholesterol stuck to the inside of an artery like grease clinging to a kitchen pipe. That image is completely wrong, and if you don't understand the disease, you can't fight it. So let me show you what's really happening inside your arteries right now. The true nature of arterial plaque. Your arterial wall is not a simple tube. It's a complex, living structure with multiple layers. The innermost layer, the one touching your blood, is called the endothelium. It's a single layer of specialized cells that acts as a sophisticated barrier. These endothelial cells aren't passive. They're constantly working, producing molecules that regulate blood flow, prevent clotting, and keep the artery flexible. The most important molecule they produce is nitric oxide. This gas keeps your arteries dilated, smooth, and slippery. It prevents blood cells from sticking. It stops the first domino from falling. But here's what happens when things go wrong. When your endothelium is damaged by high blood sugar, high blood pressure, smoking, chronic stress, or inflammation, it becomes dysfunctional. The cells stop producing adequate nitric oxide. The smooth surface becomes sticky. Gaps form between cells, and through those gaps, LDL cholesterol particles start sneaking into the arterial wall. Now, this is critical. LDL entering the wall isn't automatically a disaster. Your body has mechanisms to remove it. The problem starts when that LDL gets trapped and undergoes oxidation. Oxidation is essentially biological rusting. The fats within the LDL particle become rancid. The proteins become damaged. The particle transforms from a normal component of your blood into something your immune system recognizes as a threat. Your body thinks oxidized LDL is an invader, like a bacteria or virus. So it sends in immune cells called monocytes. These cells squeeze through the damaged endothelium, enter the arterial wall, and transform into macrophages, the soldiers of your immune system. The macrophages see the oxidized LDL. They recognize it as dangerous, and they eat it. This is supposed to help. The macrophages are trying to clean up the mess, but here's where the tragedy begins. The macrophages get overwhelmed. They keep eating oxidized LDL, but they can't process it fast enough. They swell with lipid. They become engorged. They transform into what we call foam cells, bloated immune cells that look foamy under a microscope. These foam cells are the building blocks of plaque. They're trying to protect you. They're doing their job, but they get stuck. They can't leave the arterial wall. They can't transport the cholesterol back out. So they just accumulate layer upon layer, year after year. Eventually, the foam cells die. They burst open and release their contents into the arterial wall. Cholesterol crystals, inflammatory debris, cell fragments. This triggers more inflammation, which recruits more immune cells, which creates more foam cells. The plaque grows, and over time, calcium deposits form. Your body tries to wall off the inflammation by laying down calcium, like scar tissue. The plaque becomes hard, calcified. Your arteries literally start turning into bone. This process can begin in childhood. Autopsies on teenagers killed in accidents often reveal the beginning stages, yellow fatty streaks in the arterial walls. The disease starts decades before symptoms appear. Why plaques kill? Here's what most people don't understand about heart attacks and strokes. They don't happen because an artery slowly narrows until it closes completely. That's not how it works. The real danger is rupture. Mature plaques have a structure. There's a core of dead foam cells, cholesterol debris, and inflammatory material. Covering that core is a fibrous cap, a thin layer of tissue holding everything together. When that cap is stable, thick, and strong, the plaque might narrow your artery, but it won't kill you. But when the cap is thin, when it's inflamed, when enzymes produced by dying foam cells start degrading it, the cap becomes fragile. It can rupture. And when it ruptures, the contents of the plaque spill into your bloodstream. Your blood is exposed to material that triggers immediate, massive clotting. A clot forms on the spot. It can completely block the artery within seconds. If this happens in your coronary arteries, you have a heart attack. If it happens in your brain, you have a stroke. If it happens in your leg arteries, you develop acute limb ischemia. And here's the terrifying part. The plaques that rupture aren't necessarily the biggest ones. A plaque that's only blocking 40% of the artery, a plaque that wouldn't even show up as significant on a stress test, can rupture and kill you. Because rupture depends on composition, not size. It depends on how inflamed the plaque is, how many foam cells are dying inside, how thin the cap has become. This is why the conventional approach fails. Cardiologists focus on the degree of blockage. If it's less than 70%, they watch and wait. But a 50% blockage with a thin cap is more dangerous than an 80% blockage with a thick, stable cap. We're treating the wrong thing. We're measuring the wrong thing. We need to stabilize plaques. Better yet, we need to reverse them. We need to pull the cholesterol out of the foam cells, out of the arterial wall, back into the bloodstream where it can be transported to the liver and eliminated. This process exists. It's called reverse cholesterol transport, and it's the only proven way to make plaques regress. Reverse cholesterol transport, your body's healing mechanism. Your body has a built-in system for removing cholesterol from tissues and returning it to the liver for excretion. The key player is HDL, high-density lipoprotein. You've heard it called good cholesterol. But that name is misleading because HDL isn't really cholesterol at all. It's a transport particle, a taxi. Its job is to pick up cholesterol from peripheral tissues and bring it home to the liver. When a functional HDL particle encounters a foam cell in the arterial wall, something remarkable can happen. The HDL docks on the foam cell's surface. It interacts with a protein called ABCA1, ATP binding cassette transporter A1. This protein acts like an exit door. When activated, it pumps cholesterol out of the foam cell and loads it onto the HDL particle. The HDL carries the cholesterol away. The liver receives it. The liver excretes it into bile. The bile enters your intestines. The cholesterol leaves your body. The foam cell shrinks. The plaque regresses. Healing occurs. This is reverse cholesterol transport, and activating it is the key to actually reversing atherosclerosis. But here's the problem. In most people, this system is barely functioning. ABCA1 isn't adequately activated. HDL particles aren't fully functional. The exit doors are closed. Cholesterol keeps entering the arterial wall, but it can't get out. The plaque keeps growing until it ruptures, until you end up in my cath lab at 3 a.m. with a heart attack. But what if you could open those exit doors? What if you could activate ABCA1? What if you could supercharge reverse cholesterol transport? You can. Not with medication, not with surgery, with food. Specific foods containing specific compounds that activate specific molecular pathways. This is the meal I'm about to describe. Margaret's story. Before I give you the protocol, let me tell you about Margaret. Margaret was 61 years old when she first came to see me. She'd been referred after an abnormal stress test. Her primary care doctor was concerned. We did a coronary angiogram. What I saw was sobering. Her left anterior descending artery, the widowmaker, had a 55% blockage. Her circumflex artery had a 40% blockage. Her right coronary had scattered disease throughout, not severe enough to warrant stenting or bypass, but significant enough to worry me. I looked at her lifestyle. She was doing everything her doctors had told her to do. She'd been on a low-fat diet for 15 years. She ate skinless chicken breast, egg whites, whole grain bread. She avoided butter, avoided olive oil, avoided anything with fat. She'd been on a statin for a decade. Her LDL was 85. By conventional standards, she was a model patient, but her arteries were full of disease. I asked about her HDL. It was 38, extremely low. Her triglycerides were 180, too high. Her HDL to triglyceride ratio, which I consider one of the most important markers of metabolic health, was terrible. Her reverse cholesterol transport was crippled. I explained to Margaret that her low-fat diet was actually making things worse. By eliminating fat, she'd dropped her HDL. Without adequate HDL, she couldn't remove cholesterol from her arterial walls. She was essentially trapping the disease inside her body. She was skeptical. For 15 years, every doctor had told her to avoid fat. Now I was telling her to eat it? I explained the mechanisms. I showed her the research. I gave her the protocol I'm about to give you. Margaret changed her diet that week. She started eating the meal I'm about to describe. Every single day, no exceptions. We repeated her angiogram 22 months later. The 55% blockage in her LAD had decreased to 45%. The 40% blockage in her circumflex had decreased to 35%. Her scattered disease had stabilized. Her HDL had risen to 58. Her triglycerides had dropped to 95. Her ratio had dramatically improved. Her plaques were regressing. Margaret is 68 now, 7 years later. No heart attack, no stroke, no procedures. Her arteries are healthier at 68 than they were at 61. That's what this meal can do. The arterial restoration meal. This isn't a recipe. It's a therapeutic intervention. Every component targets a specific pathway. Every ingredient has a specific mechanism. You cannot modify this. You cannot substitute. You cannot do half of it and expect results. This is precision nutrition. Component 1, the endothelial activator. You need dark leafy greens rich in dietary nitrates. Specifically, I recommend a combination of watercress and spinach. Here's why. Your damaged endothelium has lost the ability to produce adequate nitric oxide. This is one of the earliest and most critical abnormalities in atherosclerosis. Without nitric oxide, your arteries can't dilate properly. Blood flow is impaired. The endothelium becomes sticky and permeable. But there's a backup pathway. When you eat nitrate-rich vegetables, the nitrate is absorbed into your bloodstream. It circulates to your salivary glands, which concentrate it. About 25% of circulating nitrate gets secreted back into your saliva. Now, here's the key. Bacteria in your mouth, on your tongue, and gums possess enzymes that convert nitrate into nitrite. When you swallow, this nitrite enters your stomach, where acidic conditions convert some of it directly into nitric oxide. The remaining nitrite is absorbed and travels to your blood vessels, where it's converted to nitric oxide within the endothelium. This is called the enterosalivary pathway. It allows you to restore nitric oxide production even when your endothelium is dysfunctional. Human studies have confirmed this works. Researchers gave subjects nitrate-rich vegetable juice and measured blood pressure, arterial stiffness, and endothelial function. All improved. Blood pressure dropped by several points. Arteries became more flexible. Endothelial function increased measurably within hours from vegetables. But there's a critical warning. This pathway requires oral bacteria. If you use antibacterial mouthwash, if you use chlorhexidine or alcohol-based rinses, you kill these bacteria. The pathway stops working. Nitrate in your diet no longer converts to nitric oxide. Studies have proven this. Subjects who used mouthwash for 1 week showed complete abolition of the blood pressure lowering effect of nitrate-rich vegetables. Their oral bacteria were dead. The pathway was broken. If you want this to work, stop using mouthwash immediately. Brush your teeth. Floss. Use a tongue scraper. That's enough for oral hygiene. Don't sterilize your mouth. How much do you need? Research suggests 400 to 600 milligrams of dietary nitrates daily for optimal effect. 2 cups of watercress provides about 250 milligrams. 2 cups of spinach provides about 200 milligrams. Combined, you're hitting the therapeutic range. Use them as the base of your meal, raw, not cooked. Heat degrades nitrates. Make it a large salad. This is your foundation. Component 2, the cholesterol extraction activator. You need high-quality extra virgin olive oil, not regular olive oil, not light olive oil, not refined olive oil. Extra virgin, cold-pressed, high-phenolic olive oil. Here's the mechanism. Extra virgin olive oil contains a compound called oleocanthal. This is a phenolic compound that gives high-quality olive oil its characteristic peppery, throat-catching bite. That slight burning sensation when you swallow good olive oil? That's oleocanthal. Oleocanthal does something remarkable. It upregulates the expression of ABCA1. Remember, ABCA1 is the exit door that pumps cholesterol out of foam cells. When ABCA1 expression increases, more exit doors appear on foam cell surfaces. More cholesterol can be ejected. Reverse cholesterol transport accelerates. Cell studies have demonstrated this directly. Researchers treated macrophages with oleocanthal and measured ABCA1 expression and cholesterol efflux. Both increased significantly. The foam cells were shrinking. But the evidence goes beyond cell studies. The PRE-DIMED trial was a landmark study conducted in Spain. Over 7,400 participants at high cardiovascular risk were randomized to 3 dietary patterns: a low-fat diet, a Mediterranean diet with nuts, or a Mediterranean diet supplemented with extra virgin olive oil. The olive oil group consumed approximately 1 liter per week, about 4 tablespoons daily. After 5 years of follow-up, the olive oil group had a 30% reduction in major cardiovascular events compared to the low-fat group. 30% fewer heart attacks, strokes, and cardiovascular deaths from olive oil. The low-fat group, doing exactly what they'd been told to do by mainstream medicine, had the worst outcomes. But here's the critical point. Not all olive oil works. The olive oil used in PRE-DIMED was high in phenolic compounds. Fresh, cold-pressed, unfiltered. The oleocanthal content was high. If you buy cheap olive oil that's been sitting on a supermarket shelf for years that's been refined and filtered, you're not getting oleocanthal. You're getting fat with minimal bioactive compounds. It won't activate ABCA1. When purchasing olive oil, look for these indicators. Extra virgin designation. Cold-pressed. A harvest date within the past year. Dark glass bottle to prevent light degradation. Single estate or single origin. And do the taste test. Good olive oil should taste peppery, slightly bitter, and cause a catching sensation in your throat. If it tastes bland and smooth, the phenolics are low. Use 3 to 4 tablespoons daily. Drizzle it generously on your leafy green salad. Don't be conservative. This is therapeutic. Those calories are medicine. Component 3, the calcium controller. You need vitamin K2, specifically menaquinone 7 or MK7. This is different from vitamin K1, which is abundant in green vegetables and primarily affects blood clotting. Vitamin K2 is involved in calcium metabolism. Its job is to ensure calcium goes to the right places, into your bones and teeth, and stays out of the wrong places, your arteries. Here's how it works. Your arterial smooth muscle cells produce a protein called matrix GLA protein, or MGP. When properly activated, MGP is a potent inhibitor of vascular calcification. It binds calcium crystals and prevents them from depositing in your arterial walls. But MGP requires activation by vitamin K2. Without adequate K2, MGP remains inactive. It can't bind calcium. Calcification proceeds unchecked. This is why coronary artery calcium scores are such powerful predictors of cardiovascular events. A high calcium score doesn't just indicate plaque burden. It indicates K2 deficiency and dysfunctional calcium metabolism. Population studies have shown that people with higher K2 intake have lower rates of coronary calcification and cardiovascular death. In the Rotterdam study, subjects in the highest third of K2 intake had a 52% lower risk of severe aortic calcification and a 57% lower risk of coronary heart disease death compared to subjects in the lowest third from diet. Intervention studies have shown that K2 supplementation can slow or halt the progression of coronary artery calcification. In subjects taking MK7 supplements, calcium scores increased more slowly than in controls. Some studies have shown stabilization or slight regression. The best food sources of K2 are fermented foods. Natto, a traditional Japanese food made from fermented soybeans, is the richest source, containing roughly 1,000 micrograms per 100 grams. Aged cheeses like Gouda, Edam, and Brie contain moderate amounts, roughly 75 micrograms per 100 grams. Egg yolks from pasture-raised chickens contain small amounts. For this meal, I recommend one of two approaches. If you can acquire natto and tolerate its distinctive texture and flavor, consume 40 to 50 grams daily. This provides roughly 400 to 500 micrograms of MK7, a highly therapeutic dose. If natto isn't feasible, include 60 to 80 grams of aged Gouda or Brie in your meal. This provides roughly 50 to 60 micrograms of K2, adequate but not optimal. Alternatively, or additionally, take an MK7 supplement. The dose used in most studies is 180 to 200 micrograms daily. Take it with your meal because K2 is fat-soluble and absorbs better with dietary fat. The olive oil in your salad will enhance absorption. Component 4, the oxidation shield. You need pomegranate, specifically the arils, the seed sacs. Remember, the cascade of atherosclerosis begins when LDL cholesterol oxidizes within the arterial wall. If you can prevent that oxidation, you can prevent foam cell formation. You can prevent plaque growth. Pomegranate contains a class of compounds called punic alagens. These are large polyphenolic molecules that have remarkable antioxidant properties. But their importance goes beyond simple antioxidation. Punic alagens bind directly to LDL particles. They coat the LDL surface. They protect the lipids and proteins within the LDL from oxidative damage. The LDL becomes resistant to oxidation. If LDL doesn't oxidize, macrophages don't recognize it as foreign, they don't eat it. Foam cells don't form, plaque doesn't grow. Human studies have demonstrated this. Researchers gave subjects pomegranate juice daily for 1 year. They measured carotid intima media thickness, a marker of arterial plaque. The thickness decreased by 30% in the pomegranate group while it increased by 9% in the control group. Plaque regression from pomegranate. When researchers examined the mechanism, they found that LDL oxidation susceptibility had decreased dramatically. The LDL particles were protected. Pomegranate also increased the activity of paraoxinase, an enzyme that travels with HDL and helps break down oxidized lipids. Additionally, pomegranate contains compounds that enhance nitric oxide availability by protecting nitric oxide from degradation by free radicals. This synergizes with the dietary nitrates from your leafy greens. For this meal, include half to 1 cup of fresh pomegranate arils. Scatter them over your salad. They add color, sweetness, crunch, and potent bioactive compounds. Do not use pomegranate juice. The juice lacks the fiber of whole arils and contains concentrated sugars. The whole fruit is superior. Component 5, the omega-3 stabilizer. You need a source of long-chain omega-3 fatty acids, specifically EPA and DHA. The best source is fatty fish, salmon, mackerel, sardines, anchovies. Here's the mechanism. Omega-3 fatty acids incorporate into cell membranes throughout your body, including the endothelium and the macrophages within arterial plaques. They shift the inflammatory balance. When omega-3s are abundant in cell membranes, cells produce fewer pro-inflammatory signaling molecules and more pro-resolving molecules. Inflammation decreases. The immune reaction within plaques calms down. More importantly, omega-3s stabilize plaques. They thicken the fibrous cap. They reduce the activity of enzymes that degrade the cap. They make plaques less likely to rupture. The Reduce It trial showed that high-dose EPA supplementation reduced cardiovascular events by 25% in high-risk patients already on statins. The benefit wasn't from cholesterol lowering, it was from plaque stabilization and inflammation reduction. For this meal, include 100 to 150 grams of fatty fish. Wild-caught salmon is ideal. Sardines and anchovies are excellent and economical alternatives. Bake it, grill it, poach it, don't fry it. Serve it alongside or on top of your salad. If you're vegetarian or allergic to fish, consider a high-quality algae-based omega-3 supplement providing at least 500 milligrams of combined EPA and DHA. Assembling the meal. Let me give you the complete picture. Start with a large bowl or plate. Add 2 cups of watercress and 2 cups of spinach. These provide your dietary nitrates. Add half to 1 cup of pomegranate arils. These provide punicolagens for oxidation protection. Drizzle generously with 3 to 4 tablespoons of high phenolic extra virgin olive oil. Add a pinch of sea salt. Toss to combine. The olive oil provides oleocanthal for ABCA1 activation. Add 100 to 150 grams of baked or grilled fatty fish, salmon, mackerel, or sardines. This provides omega-3s for plaque stabilization. Include 50 grams of natto on the side, or 60 to 80 grams of aged Gouda or Brie, or take an MK7 supplement with the meal. This provides vitamin K2 for calcium control. That's the meal. Nitrates for nitric oxide production. Oleocanthal for reverse cholesterol transport activation. K2 for calcification prevention. Punicolagens for oxidation protection. Omega-3s for plaque stabilization. 5 mechanisms. 1 meal. Synergistic effects that amplify each component. Implementation. Eat this meal once daily. I recommend lunch or early dinner. The nitric oxide boost will peak 2 to 3 hours after eating, giving you enhanced blood flow during your active hours. Eat slowly. Chew thoroughly. The nitrate conversion depends on oral bacteria having adequate contact time with the nitrate in your food. Rushing undermines the process. This must be daily, not 3 times a week, not when convenient, daily. This is a therapeutic intervention. Consistency is non-negotiable. Addressing concerns. I know what objections are forming in your mind. First, the fat content. 4 tablespoons of olive oil is roughly 500 calories. Isn't that too much fat? No. The low-fat mythology has caused immeasurable harm. For decades, we told people to avoid fat and eat more carbohydrates. The result was an explosion of obesity, diabetes, and metabolic syndrome. Heart disease rates didn't improve. Disease rates. Fat doesn't cause atherosclerosis. Oxidized LDL causes atherosclerosis. Inflammation causes atherosclerosis. Dysfunctional HDL causes atherosclerosis. When you remove fat from your diet, your HDL drops. Without adequate HDL, reverse cholesterol transport fails. Cholesterol gets trapped in your arteries. Plaque grows. When you add healthy fats, particularly olive oil, HDL increases. ABCA1 is activated. Reverse cholesterol transport improves. Plaque regresses. The pre-dimed trial proved this definitively. The high-fat olive oil group had far better outcomes than the low-fat group. The science is clear. Second, this seems expensive. Quality olive oil, fresh pomegranates, wild salmon, aged cheese. This adds up. Yes, it costs money. Maybe $15 to $20 per day for all components. That's $400 to $600 per month. But consider the alternative. A coronary stent costs $50,000. Bypass surgery costs over $100,000. A heart attack requiring ICU care can cost hundreds of thousands. And that's if you survive. If you don't survive, the cost is infinite. This meal is the cheapest health insurance you can buy. Third, what about statins? Is this meant to replace medication? No, this is meant to complement medication. Statins lower LDL. They reduce the amount of cholesterol entering your arterial walls. That's valuable. But statins don't activate reverse cholesterol transport. They don't remove cholesterol that's already trapped in plaques. They don't stop calcification. They don't prevent LDL oxidation. Statins treat one mechanism. This meal treats 5. Use both. Fourth, can I substitute ingredients? No. Each component targets a specific pathway. If you remove the olive oil, you lose ABCA1 activation. If you remove the pomegranate, you lose oxidation protection. If you remove the leafy greens, you lose nitric oxide restoration. This is a synergistic protocol. Every piece matters. Follow it as written. Monitoring progress. If you want objective evidence that this is working, you need to measure the right things. Leave a comment. Tell me your situation. Tell me if you have arterial disease, what your numbers are, whether you're going to try this protocol. Every comment signals to the algorithm that this content is valuable. Your comment could literally save someone's life. I'm Dr. Olivia. Take care of your heart. I'll see you in the next video.